just on overpayments on Medicare. Medicare, there's a lot of wasteful spending in Medicare. So we don't necessarily have to cut benefits, but what we do have to do is figure out where a lot of this waste is coming from. And we will be able to do that rather quickly with this healthcare reform bill, and then that will extend the life. I think it's projected at least 5 more years into Medicare. So, but you can't underestimate the significance of all of a sudden you have today you have thousands of people going into the Medicare program who wait to get their hip operation, wait to get their heart surgery, wait to get anything significant done because they know Medicare is going to pay for it. And all of a sudden, those people, and if you do that, you become chronically ill. And so now Medicare has to deal with people who are really, really much sicker than they needed to be. And through this reform, we'll be able to put a healthier customer, a healthier patient into the Medicare program, and that's going to extend the life.
Okay. Thank you. We have a question brought to us via Facebook. Deb Lavelle sends us this question. Congressman, if health insurance becomes mandatory, how will people making $8 to $10 an hour afford it if there is no public option to make a competitive market?
Well, first of all, I think there's some confusion that the public option would only be where poor people or people who have lesser means would go. The public option would be for everybody. Here's basically what's going to happen. We're going to set up an exchange, basically a supermarket, where you can go and all of the private insurers can go and participate in this market. And what we're going to do is set up a panel, not a deaf panel, but a panel. I'm afraid to even use the word panel anymore. Headed by the Surgeon General with healthcare providers, docs, who will set up what's called the Essential Benefits Package. And so no matter what private insurer goes into this exchange or the public option, they will all have this Essential Benefits Package, which will be basic care, headed up by the Surgeon General. So dental, eye, maternity, hospital visits, prevention, those kinds of things. So whoever goes to the marketplace, like this gentleman wants to do, there will be an Essential Benefits Package, and the public option, should it survive, would just compete with all of these other private options as well. But there would be a baseline of coverage. So the public option isn't just where certain people would go. Anyone could vie to go to the public option if they wanted to. Now, there will be exemptions for people who just flat out don't make enough money and for whatever reason, for some extraordinary circumstance, can't get in. But that person would either qualify for Medicaid, which would be up to 133% of poverty, or once Medicaid ends, then they would be heavily subsidized to go out and purchase care. So that person will be able to access coverage, but they will have to get into the system. At some point, they will have to get coverage, and they will be subsidized, and they will be able to afford it. Now, here's also what's going to be a benefit to everybody. If that person today doesn't have health insurance, they make $8 to $10 an hour, they don't have a health insurance plan. They get sick, they wait, they hope their cold goes away. They end up in the emergency room. They end up in the emergency room for a long time. And you can talk to local hospitals here and they will tell you the amount of charity care they have to provide. That person pays nothing now. Under our plan, that person will, A, have to get coverage. They will get subsidized. But they will have a copay. They will have a premium that they have to pay. They will have skin in the game. Okay? Because everyone's got to, if we're going to do this, everyone's got to participate. So although there will be subsidies for this person, because we want to incentivize it for them to get health care, they will still have something that they have to come out of pocket with.
Where will those subsidies come from?
They will be paid for by, one is the savings that we're going to have in Medicare. There will be a surcharge, well, and this is all going to be debatable and negotiated out, but there will be a surcharge on families who make more than $1 million a year will have to pay 0.9% of their income. So a household making $1 million would pay about $9,000 a year. There would be people who make $350,000 or more would have to pay some as well. And that's where the money would come from, plus the savings in Medicare and some other things. But now all of a sudden we have a group of people, 30 million, there's all kinds of different numbers for, you know, how many uninsured there are. But these people will now be contributing to some extent to their own health care coverage. So we'll be getting some money from them as well.
Okay. Next, I'd like to call on Bob Schroeder, who's the Chief Executive Officer of Humility and Mary Healthcare Systems. The Congressman just mentioned a moment ago, Bob, about the millions of dollars that hospitals provide in charity care. In HMMP's case last year, how much did HMHP give in free care to this community?
About $45 million, and that's an actual cost. So that's the cost of providing the service. If you look at charges, it was well over $80 million. So I'm going to kind of stick to the same theme a little bit and kind of incorporate some of the things that we've just been talking about, and that is when, and again, remember this is from a hospital administration perspective. When I look at Medicare and Medicaid, they pay hospitals below the cost. Medicaid pays hospitals about 70% of cost, Medicare about 85% of cost. And again, this is cost, not charges. There's a concern on the provider point of view that a public plan or even a cooperative plan will pay similar, you know, somewhere between Medicare and Medicaid, you know, some fraction of cost, which then means that the difference between the cost to somebody in a public plan would have to be passed on to commercial payers, which is then going to make that differential between the commercial payers and the public or cooperative plans even greater, which will eventually drive out the commercial plans altogether. I was just wondering what your perspective of that and what you see in the healthcare reform bill that could potentially stop that from happening.
Well, the House bill has there have been two approaches. One was for the public option, the reimbursement would be Medicare plus 5%. So it would actually be an increase for you. That was amended to, I believe it's Medicare, from Medicare plus 5 up to the highest private insurance reimbursement in that region, I think is how it ended up. Now again, this is all, you know, going to be negotiated. I don't know if it will be exactly one of those or not. But in both instances in the House bill, you'll at the very least get Medicare plus 5%.
A follow-up,
Bob? Well, can I switch subjects a little bit?
Sure.
Defensive medicine obviously also drives up the cost, and you were talking about a lot of waste in the system. And I think there is a lot of waste in the system because of defensive medicine. And I was just wondering your perspective of healthcare reform trying to deal with that issue.
You know, I know this isn't very popular necessarily among Democrats, but I believe that we need to address the issues of defensive medicine and the issues of liability. I just think I've talked to too many doctors who have said to me they do tests because they fear that they may get a lawsuit and they didn't cover their own rear ends. And so I think we've got to be able to work something out with the lawyers and the docs to where we can all agree this can't, you know, we can't let this prevent healthcare reform from happening. To where a group of cardiologists, there's got to be a standard of care. Now, we're not saying protect the surgeon that amputates the wrong leg and all of a sudden the consumer now, or the patient is going to get punished because now they had both legs amputated and they have no recourse in the courts. But what we should say is if we have 10 cardiologists who, given this situation, all do the same thing, and this is the proper way to address whatever the situation that they have to deal with, and that particular cardiologist who's being accused of whatever went through all of the details and did everything that everyone else would have done, there should be something in the law that allows that doc to be comfortable. You know, practicing medicine is an art. It's not a science all the time. It's feeling your way through things. And I think if you take that away from the doctor, I think you're taking some of the magic out of the doctor-patient relationship, and I think that needs to be protected. So